Good morning, my name is Glen Foley and I'm going to talk to you about angular rotation of the adult lower limb. Angular deformity has been defined as an angulation around an axial or longitudinal axis on the long bones of the lower limb. This can result in changes in relationship between the hip, the knee and the feet. And this is certainly true of the long bones in the lower limb, such as the femur or tibia. However, other causes exist, which we'll explore during the course of this presentation and look at rotational deformity in the adult lower limb. We know that rotational deformity is common in early childhood and generally resolves by musculoskeletal maturity. However, in some adults, rotational deformity still exists. As a result of this, we need to be mindful as it presents quite an interesting clinical picture and can lead to significant bearing on our etiology and our intervention with that patient. The change in angle may result also in changes in timing, moments and forces acting around the joints, muscles and bones of the lower limb. And again, we need to be able to identify these and look at the correlation with the etiology that we're presented with, because it will be important to know that when we decide upon our interventions, be it orthotic or musculoskeletal. So where do lower limb rotation deformities exist? They can exist anywhere in the lower limb. Examples would be at the hip with femoral anteversion presenting as in-toeing, rotation of the femur and the tibia, at the knee such as OA or traumatic instance where the knee has been left in an unusual position, all the way down to the foot where we can look at metatarsus adductus. If we look at in-toeing as an example, at the different levels of rotational deformity, we can look at the hip with femoral anteversion resulting in in-toeing position. We can look again at the femur and the tibia resulting in torsion, medial torsion, what would lead to an in-toeing gait. And also at the knee, generally with OA, we can lead into a varus position. And then again down to the foot where you can end up with a metatarsus adductus. These would present quite similarly in a dynamic picture. However, I think you'll agree that we'd probably treat them quite differently in a clinical way. It's also worth noting at this point that rotational deformity can actually counteract each other. So a proximal deformity of the hip, such as femoral anteversion resulting in in-toeing, could actually be counteracted below the knee by tibial torsion, resulting in an abducted foot position. These opposing forces can lead to a horrible condition called miserable malalignment syndrome, which is a very difficult clinical picture to treat. And what we're going to look at is the ability to identify those and look at how we can identify those with the correct assessment tools. So let's take a closer look at the hip. If we think about the hip, we know as clinicians that you can get soft tissue causes of internal and external rotation with tightness of the abductors or adductors. This can be generally corrected very well by inputs by the physiotherapist, and it does is able to be picked up very easily with use of Feder's and Fabers as part of our clinical assessment of the hips. If we now think of the osseous causes in hip rotation, and if we think about the relationship of the ball and socket joint, the femur in the acetabulum, and we can surmise that if we looked at any rotational deformity of the femur, it can result actually from the relationship between the femoral head and the acetabulum. So any deformity existing within the acetabulum or femoral head can lead to a rotational deformity of the lower limb. Further to this, torsion occurring at the distal femur or at the neck of femur would have to be accommodated to allow correct seating of the femoral head within the acetabulum, and that would have to be compensated once again with external or internal rotation of the lower limb. This presents quite a tricky clinical picture as it's not easy to correct this without surgical intervention. Oh, here we go. Moving down to the level of the knee, we come to the pivotal point of compensation for rotational deformity. Although the knee is rarely the primary cause of rotational deformity in the lower limb, it does play a key role in mitigating the effects of rotational deformity at the proximal or distal level of the lower limb. Rarely you will see the knee being a primary cause, but in such cases of OA and surgical intervention or trauma, you may see a cause of rotational deformity as a direct cause of the knee position. Soft tissue injury to the knee, such as ligamentous injury, can lead to laxicity, and this can lead to rotational deformity as a result of that laxicity. It's also worth mentioning this picture behind me is a classic example of hypermobility syndrome, and this is something to be mindful of when we're looking at rotational deformities, because it can affect any level of the lower limb. Use of the Beaton's or Bryson's criteria as part of your clinical assessment will help to screen this and make sure that you don't miss this as part of your clinical diagnosis. If we move down to the tibias now, we know that in-toeing in infant gait is very common and generally corrects by adult maturity. It is, however, very rare in the adult picture and is generally only seen after malunion following fracture or trauma. Out-toeing is much more common with the outcome from tibial torsion, and diseases such as Blout's or rickets have been cited as a common cause of tibial torsion. So how do we assess for rotational deformities? How can we identify at what levels those deformities exist? And how can we do it in a simple clinical environment without the use of MRI or CT scans? We have several validated tools at our disposal, and we're going to explore some of those tools now. The first of which is the Craig's test. The Craig's test is a very subjective test, which, to be honest, is part of our world. But with the Craig's test, what we're able to ascertain is the position of the hip, looking at femoral anteversion or retroversion. In order to perform the Craig's test, we ask the patient to lay down on their front, and they bend the knee of the leg that is being examined. The clinician then palpates the head of the femur while internally and externally rotating the tibia. From here, they're able to determine when the femoral head is at its most lateral position. When you say its most lateral position, we can look at the deviation from 90 degrees, and already, crikey, deviation from 90 degrees and measure that degree of angle. Normal, if we're going to use that term, we'll use it quickly here, but normal is between 5 to 15 degrees from vertical. Below 5 degrees is considered to be femoral retroversion, and above 15 degrees is considered to be femoral anteversion. It is a very subjective tool, but used in conjunction with a raft of other clinical tools and, most importantly, dynamic assessment, it can form an important basis of our clinical assessment protocol. Oh, this is a nightmare, this clicker. Oh, I'm back. Someone stitch me up. Okay. Here we go. Right, okay, sorry. Have another minute, please. Okay. Looking at rotational deformity below the knee, we can look at the foot to thigh angle, also known as the thigh to foot angle. And this is a useful clinical tool to look at tibial torsion. Again, the patient is laying on their front and the examining foot is having the knee bent. We place the foot into subtalar joint neutral and use a bisecting line between the centre point of the calcaneum down through the second metatarsal and compare that line to the line of the femur. We then measure that angle with the gomiometer and look at the angle that exists. Again, we'll use normal as a word. You can jump all over me for that later. But 0 to 10 to 15 degrees is considered normal. Below 0 degrees is considered to be an adducted position. Above 15 degrees is considered to be an abducted position. The subjectivity in this is even greater because of the placement of the bisecting lines, and the uses of gomiometer is open to huge interpretation. However, it is a useful tool as a basic aid to look at rotational deformity below the knee. Oh my goodness. Standing assessment. This is again a useful tool to corroborate what we've seen in the non-weight bearing assessment, and it is limited, as we know, but it does allow us to look at some of the compensations that occur in a static position. Interestingly, Lin et al. In 2016 looked at standing measurements and found that it had no correlation to injuries in amateur runners whatsoever, apart from patellofemoral pain. His adjunct to that was that static measurements may be injury specific. Now, I think we can all agree that static measurement has a huge limitation in what we're looking at, and dynamic is the key. But it's my opinion that we need to ascertain exactly what's going on at a biomechanical makeup level before we can work out what's happening in the dynamic picture. And certainly with the case of torsional rotation in the lower limb, I think we need to ascertain that before we look at the dynamic picture. So, how does this affect our clinical picture and our orthotic prescription and intervention? If we consider rotational deformity in the context of MTSS, and if we look at MTSS and its causative factors that have been cited, namely soleus, tibialis posterior, flexor digitorum longus, and bending moments on the tibia, and then think about an abducted foot position and something simple as pronation moments, we can consider that the abducted position of that rotational deformity could indeed have a significant bearing on the presentation of MTSS. Interestingly, a reference I've forgotten, interestingly, Hamstra and Wright et al. In 2004 did a systematic review of MTSS and found that an externally rotated hip position is one of the 4 key factors in MTSS presentation. Now, I hope from this very short talk today it's whetted your appetite to look further into rotational deformities and the ability to look at this in a clinical setting with these simple tests. And I hope that you can employ it in part of your clinical assessment tools. Thank you very much.